I'm going to talk about a model which we developed at Farnfield Hospital, which is looking at as a multimodal approach to achieving patient transparency in structured professional judgment risk assessment processes. Risk assessment is one of the core things that we do in forensic services, and I think traditionally we've been quite poor at involving service users in that process. There's a lot of people who we're quite scared of what will happen if we involve people, what will happen if they find out what the sort of things that we're saying about them. But I think with all the work around recovery, there's a big move now to including service users in their risk assessments, to involve them, for them just to know a bit about what risk assessments are about. And I think at Farnfield we thought, actually we need to do something about this. We need not just to say that's what we need to do, we actually need to actively do something. So we sort of thought about why do we need transparency? Well, there are things like the Department of Health best practice principles, and that talks a lot about sort of service user involvement in risk assessment, things like the recovery ethos, how we involve service users more in what's going on generally. Risk generally is an important component of insight in forensic patients, and I think it's something that I think if you look at what you're doing in your own service, or what we did sort of 5 years ago, actually we would talk about these risk concepts, and patients would have very little idea about what we were talking about. And when we did a study looking at what patients said about risk assessment, actually a lot of people in the hospital didn't even know what risk assessment, what the words meant. They had absolutely no idea. So again, we're moving from doing things to patients to doing things with patients. And if we want to achieve sort of proper assessment and management of risk, I think we need to be involving our service users in that process. So why don't we do it? Well, fear of impact upon the patient. We think, well, maybe the patient will become very scared, very worried about what's happening. Will they kick off? Will they fight against it? Will they argue with us if we try and say this is what we consider the risks are? The other thing is it's not actually that easy to achieve. So I think we've done some things about trying to work through how we get patients involved, but it isn't that easy. It is a bit more time consuming, and I think that's sort of stopped us a lot from doing that in the past. And it also requires a cultural change amongst professionals. We have to accept that that's part of what we do, and that becomes commonplace, and not just go, it's something extraordinary, something that we're not going to do. We'll only do with the patients really who are well towards the end of their stay, who we think aren't going to make a big fuss about it. So what we thought we'd try and do is we thought we'd have, first of all, I'm going to talk a little bit about the patient education. So what we thought very much was the case was that we educate staff about risk assessments, but we don't educate patients. We don't really actually know what risk assessments are, but we're expecting them to take part in them without them knowing. So we thought that's an important point. I'll talk about what we did about that in a minute. We wanted to more collaboration in the actual process of risk assessment meetings, and we wanted patient-friendly presentations of information. So I'll talk a little bit about each of those ones. So we thought also, what happens when we exclude patients or service users from our risk assessment process? Well, we thought about what happens if we're excluded from a process which is about us. And I think if you're excluded, you're not given information about it, I think that develops a lack of trust, isn't it? We don't tend to trust people. We think, what are they doing? What are they saying? They're writing things about us, but actually we don't know what it is. So the exclusion leads to a lack of trust. Non-cooperation, we see that a lot, don't we, within forensic services. Patients thinking, well, I'm not going to cooperate because I don't actually know what you're talking about, and actually if I just come into a meeting, you're actually just going to say something which I don't like anyway. So it tends to lead to non-cooperation and rejection, because we're going to reject things which we don't like, that we don't agree with. Denial of some of these aspects of what's going to be the result, and may lead to some sort of cognitive distortions about the process. And avoidance, so patients might avoid talking about their risks, not want to be involved in any of those aspects. And what we're going to get, which we often have, is the two sides going in different directions. We have sort of professionals who are writing risk assessment, and service users who the risk assessments are all about, but going, I'm not going to have anything to do with it, and there's a lack of understanding about it. So what we want to try and achieve is more inclusion. So thinking about collaboration and transparency. We want a collaborative approach which is more transparent, so that all the patient service users know what the process is. We want to build up that trust. Hopefully if people know what we're actually talking about, they will feel more trusting in the system and feel that they're not going to be, somebody's going to do something to them which will hinder them in some way. We want to create working alliances so that we're working with patients and service users towards achieving the same aims. Coming up with a shared formulation. Getting patient service users to internalise those risks and understand what the risks are that we see, and then feel motivated to change. So they're much more likely, we think, that if you understand what you're being asked to do, you understand what your risks are, that you're much more likely to change it. And hopefully then what we get is things fitting together and people working together. So that was sort of our model of what we wanted to try and achieve. So the first part was around patient education. And so what was developed at Farnfield was a group called the Safety Planning Group. So we decided very much that we didn't want to call it a risk assessment group or education about risk assessment, because that was, again, had quite a negative connotation. So what we decided to call it was a safety planning group. So, talked a little bit about, we give staff a lot of education about risk assessment. So at Farnfield, we were generally giving staff about 4 days worth of education about risk assessment, about learning about risk assessment. We had an initial day which was called Clinical Risk Assessment and Management, which was all about a bit about what risk assessment was, service user involvement, formulation, those sorts of things. And then we had separate days which were about the HCR20, the START and the SAPRA, which is a protective factors assessment. So all our staff were going through 4 days of education about risk assessment, yet you were expecting service users to come along to meetings, no education at all, didn't know what it was, didn't know anything about it. So we felt, well, this was a bit unfair, really, wasn't it? We needed to readdress this balance. So one of my colleagues set up a safety planning group, and this is a group for patients which is 8 sessions run over 8 weeks. It was sort of quite interactive, included sort of brainstorming, planning, goal setting, perspective taking, and it was very much about learning about what these risk assessments were about. So here are the 8 sessions. Basically, so say you learn about risk assessment, they completed the START, which was a sort of simplified version of the START, so they would understand what the START was about, looked at the HCR20 and also looked at the SAPRA. And the aim was that by the end of the group, that patients would complete a START assessment of themselves and then take it to their teams and discuss it with their teams. Okay. So to date, I think we've run six groups. 22 service users have completed the programme. So what we did is we looked at what their information was about risk assessment before the group and then at the end. So pre the group, we found that they didn't really know what risk assessment was. They said things like to measure the problem. They just didn't know what it was. They had no idea what the words meant. And post the group, what we found was they understood that the risk assessments that were complete at the hospital included the HCR20, the START, and we also use a sort of traffic light system. So there was much more understanding, at least of what the risk assessments were that we were using. So what was their understanding about risk? Well, before the group, they'd say the word risk is a euphemism for punishment, and feel that even though he has done nothing wrong, he gets punished. And post the group, they'd say things like, I now understand risk, how to work in a group, how to share time, letting others speak, understanding that there are different risk assessments and they're not all the same. Some are future and some are past. Helped me to understand risk assessment and made me aware of how to avoid some risks. So there's definitely a greater understanding by the group. So the second part of the model, so the first part was understanding a bit about what risk assessments were about. The second part of the model was about getting patients involved in their own risk assessments. So at Farnfield we have a risk assessment meeting, which is a 2-hour meeting where all the risk assessments are completed. A couple of weeks before the CPA, so sometimes it will happen a few days before, sometimes a few weeks. So the whole MDT will get together and they'll hold the risk assessment, complete them. So what we started to do was to say, well, we want to invite the patient to that meeting. There's no reason the patient can't come to that meeting. So the patient was encouraged to bring their own risk assessment, so they completed it in the group. And then there was a consensus, there was discussion about the risk assessment process. And the patient their voice had equal weighting to everybody else's. So they could discuss what they thought about their risk, would go through all the HCR20 items, and they would discuss as well and give their opinion about them. So we're not saying that anybody's opinion was counted for more than anybody else, it was a discussion. And sometimes the patient's view would sway people one way or another way. Sometimes patients gave more information about their risk. Some people wanted their score to sort of get worse. Other people tried to argue and say, no, I'm not a risk in that area. But there was a discussion, and I think it was a much more open discussion about what those risks were. So ideally, as I said, the patient would have completed the safety planning group. That's a sort of best practice. That doesn't always happen. And the patient will be invited by a letter by the MDT to attend their risk assessment. So this is from our pilot. So we had a good take-up to attend the risk assessment meetings. The majority could contribute for about 45 minutes. There was a lot of variation in terms of what patients can attend. So we tried to have an MDT meeting beforehand and just to discuss what we thought, how much the patient could attend. So for example, you get somebody at the end of their stay in hospital who's quite well, could attend the whole 2-hour meeting. You get somebody who's quite unwell, whose concentration is quite poor, they might just be able to attend 20 minutes. And then we might decide, right, okay, so should we start with the SAPROF and just do the positive and protective factors assessment? Shall we do the START, which obviously has a combination of vulnerabilities and strengths? So we'd sort of think about what was right for that person, what was right in terms of the amount of time. So sometimes we just see how much the patient could do. Sometimes patients contributed more at the beginning and then they sort of listened. And we've now been using this process for over a year. So we've got patients going through this process for the sort of the second, sometimes the third time. And I think what we find is that patients are much more involved in the process now. So at the beginning, I think quite a lot of people sort of would sit back and just wonder what on earth was going on and feel a bit sort of bombarded with things. And I think now, patients are much more, can be much more involved. They may remember things about their risk assessment. They obviously get copies of all their risk assessments. In our pilot, what we found was that some patients did find it quite stressful, and we had one person who, particularly because they were dealing with his sexual offending, found that quite difficult and went back to the ward and was quite upset about it. Generally, I think we don't find too many problems anymore. We don't find that patients particularly argue, about difficult things. They don't we don't have anybody sort of kick off. The patients just generally sort of are prepared to talk about it, and then there's a sort of process of going, well, maybe this area you've still got things to do, and this one you've addressed these areas. So the third aspect is patient-friendly information. So we thought, what we've got at the moment is very, very long risk assessments. So we've got over 40 pages of information. If you look at like an HCR20, just pages and pages, I don't think staff really look at it that much either. So you've got lots and lots of information, and what we thought was we need to simplify this really, because I don't think lots of the commissioners, staff are looking at this in great detail. So we want a simple bit of information assimilated into one page that we can just look at, and looks at 6 months ago, looks at now, sees what's happening. So this is what the sheet of paper looked like. So we've condensed the information onto one page. So at the top of the page, we've got the traffic light system. So that's based on each week's a patient is assessed according to whether they're red, amber, or green. So we're looking at that. The HCR20, you're looking at 2 time periods. The 2 different colours shows the change between the 2 time periods. And the START, again, looking at the strengths and vulnerabilities, and you've got 2 time periods, and the SAPROF. The boxes around the SAPROF, if you know the SAPROF, are around the goals and the keys. So we would move things around so you could see what the goals and the keys were. I think I personally love this form because I think it's so simple. I think it's really easy to see what's happening with the patient. You can see change over 6 months. You can see all the risk assessments in one go. And I think that it's a really easy form you can take along to ward rounds to look at what's actually happening with that person. It also highlights for you what's happening with the SAPROF, what the strengths are, and you can continue to sort of go back to some of those. So that was our solution to thinking about how we condensed all the information. I know it's still quite a lot of information to take in on one page, but it's a lot simpler than 40 pages of risk assessment. So in terms of where do we go from here? Well, we've rolled this out now across, we had a pilot initially, we rolled it out across the whole of the hospital, and it's being rolled out across the whole of Priory Secure. So we've trained all the sites in terms of the safety planning group, and I think all the sites now are using this sort of approach. There's an article that's been published by Amy Horsett, who was the person who developed the safety planning group, and Adrian Cree, published about the multimodal model, and we're looking at evaluating it through the IOP. So we're trying to look at whether it's effective. I think there is some research that shows that they're not certain about whether educating patients about risk assessment how much change that actually makes. But I think intuitively you think people should know about these things, and it may make change in terms of their motivation to change, but actually they ought to be informed, because we'd all want to be informed of things that if they were happening to us, I think, and to have much more knowledge and awareness of them. That's the end.